Good afternoon to everybody. Welcome you to this practical session. Okay, I think I'm alone. I can remove this. We are supposed to wear mask even at home. All of you know this. Okay. Hope you have taken your books along and then spend quality time reading, learning. Okay. So let me start with the first slide. This competency is competency 4.4. Okay. So what does it deal with? This competency deals with acute inflammation. Now, how are we going with this and what you are going to learn? So you should tell me. This is a case scenario. A 15-year-old boy, came to the hospital to meet, to consult Dr. L.S. Patil, and this child had fever and pain. Typically, this boy and the mother, they said the pain was near the belly button, the umbilical region. And probably on taking history, then this boy said it moves towards the lower right side of the abdomen. One or two batches, you students are posted to surgery. So I have given you a direct clue as to why this patient came to surgery. Don't wonder, because 15-year-old, maybe he is referred also by a pediatrician. And then the boy also had nausea, vomiting, loss of appetite, fever and chills. How long? This he said was 3 to 4 days. Okay, basic investigations were asked for, and I'm just giving you only few investigations, the values or the report of which might help you to make a diagnosis. So total count was 21,360 cells per cubic millimeter, or 21.360 to 10 to the power 3 microliters per microliter. What is that? 21.360 into 10 to the power 3 per microliter. Okay. So neutrophils are 76%, lymphocytes 15%, monocytes 2%, eosinophils 7%, and ESR was 69 millimeters per hour. So what do you think could be the clinical diagnosis based on the laboratory findings, the clinical presentation? So this child was immediately taken up for surgery, and since they insisted, a laparoscopic surgery was done. So what was the laparoscopic surgery? So I've given you an image here. You can make out. So what is this? So these were the clinical signs. Child had pyrexia, temperature was more, localized tenderness, muscle guarding, rebound tenderness, and all these signs you will learn in surgery. Okay. So what was the diagnosis? So the disease was pertaining to this particular organ. Okay, vestigial organ we say. It's not present in animals, only humans have no use also. Okay, so the clinical diagnosis was acute appendicitis. Fine. So now today we are learning about the acute appendicitis and gross and microscopic features of this. This is taken as an example for acute inflammation. Okay, so gross pictures, let us see. Before we see the gross picture, let's see this specimen. Are you all able to see this specimen. What is this? Hope it is visible. Can you make out? This is appendix. Should I bring it near? I think it's difficult. Okay. So this was one such appendicectomy which was removed and sent to us, which we had mounted. So have a closer look at it. So I'm showing you the surface. See the surface, this appendix is swollen, that is edematous. Surface has congested blood vessels. Congested blood vessels. You can appreciate that, I think, on the surface. Okay. Then cut section. Only the tip we are showing you, the cut section. It is blackish, right? Now you can appreciate the serosa so well, and the lumen has some blackish discoloration. Okay, it's not, what is blackish? You've learned in the previous class that gangrene or gangrenous tissue appears blackish. Probably this is hemorrhage, altered, so slightly blackish, and the surface is showing very prominent vasculature, so congestion. This is another specimen. This is very well made out. You can make it when we look at the tissue grossly, and for studying we take a section from the tip of the appendix like this. Okay, lumen is patent. Lumen is not obstructed. I'll tell you why I'm concerned about obstruction of the lumen. So even this is black in color. The surface has congested vessels. So both are acute appendicitis. So this surface has blackish discoloration. This was beginning of gangrene of the appendix, which was removed. Okay. So let us go back to the slides. We are learning about the microscopic appearance of acute appendicitis and also the macroscopic appearance, and knowing about the causes and all that. So symptoms and signs of acute appendicitis. Usually this affects children who are young people, okay, children above 5 years up to 45 we can say, unlikely in elders. Mean age is 28 years. Inflammation. You know about the chemical mediators and what causes pain and all that. So colicky pain, okay, initially around the umbilicus but later localized to right eyelid fossa. Nausea, vomiting, pyrexia of mild degree, abdominal tenderness, and increased pulse rate, neutrophilic leukocytosis. All these are the common symptoms. So it could be anything additional apart from these. And most common in older children and young adults, and uncommon at extremes of age. So this is what is important, because you need to look at the age of the patient and how he presents with also. Now, so all of you have learned about the histology of appendix. Just a recap. Appendix has 4 layers. So mucosa, submucosa, muscularis, and the serosa. So mucosa is just a simple layer of columnar cells, the inner surface. The mucosa is lined by a single layer of columnar cells. Then we see the glands there. These glands are just like the small intestine glands which are there, and extra thing is they have got goblet cells, that is mucin secreting cells, as we see in the large intestine. Then submucosa. See, this is submucosa, this one, mucosa, then this is lamina propria, submucosa. Submucosa has abundant lymphoid tissue. They are both primary and secondary lymphoid follicles. So secondary is all these, which have shown reaction. with prominent germinal center. Then the muscle layer, muscularis, is the inner circular, outer longitudinal, just like that of the intestine, large intestine. Then serosa. Serosa is the outer covering. So that is made up of connective tissue, blood vessels and all that. Then comes the fat mesoappendix, or the fat that surrounds the appendix. Okay, this is just a diagrammatic representation. Just a recap: lumen, the mucosal lining, columnar epithelium, then the glands, the submucosa with lymphoid follicles. All this is submucosa. I'm just showing you lymphoid follicles, inner circular, outer longitudinal muscles, and the serosa. Okay, see all this? Yes. So what causes acute appendicitis? So I since it is an online class, I just don't want to restrict myself to gross and microscopy or clinical scenario. So I thought, let me give you some more theoretical information also. Causes could be obstructive, non-obstructive. So what causes obstruction? So fecalith. What is fecalith? It's a concretion of fecal matter. Very hard fecal matter, which is like a lith, like a stone. It is calculi. Then foreign body. More common is a lot of parasites. Very common parasitic infestation that we see in the appendix is Enterobius vermicularis, which is commonly called as pinworm. Oxyuriasis, very common in children. You know how children complain about the perianal the skin itching, especially during the night. So when they scratch, the worm comes out during night to lay eggs around the anal skin. So child scratches, lot of eggs enter. So then the child eats without washing the hands, or when these eggs are there within the nails. So auto-infection. This is very common, and I remember one appendix which I had seen, cut section, it thousands, I should say, so many of these worms came out. I had mounted it in JJMC when I was there. So tumor. One tumor you should remember in relation to appendix is carcinoid, but this carcinoid tumors occurs only at the tip of the appendix, so less likely to cause so much of obstruction. Okay, it could be an incidental finding also for us. That's why when we gross the appendix, that is microscopy, when we see cut the appendix, we always take a cut at the tip of the appendix. Non-obstructive causes are infectious etiology. So hematogenous spread of general infection. There are so many bacteria. So don't forget, remember viral also. Then vascular obstruction or occlusion. Then same thing, fecalith, what we were talking about. Inappropriate diet, lacking roughage, low dietary fibers. This is what our youngsters are into nowadays. Eating all bakery products and pizza, burger and all that. Not much of vegetables or all that. So what happens when there is obstruction? It leads to increased intraluminal pressure, and this presses on the blood vessels. Blood vessels are there in the outer wall. So when something is causing pressure from inside, so that compresses. So ischemic injury, which in turn favors bacterial proliferation. And then bacteria, normally there is fecal matter, right? So that causes inflammation. That is there. Okay, so we'll see this pathology now. So if you think this is the appendix, so lymphatic hyperplasia is another cause for obstruction. So lymphoid follicles, which when they become hyperplastic, they cause luminal obstruction because they're in the submucosa. So there it causes intraluminal pressure increase. So edema and mucosal ulceration, bacterial translocation to mucosa. Okay, so just an analogy here. See, appendix is like this, is some fecal matter and all that secretion. So something compressing it from outside, obstruction, okay, as in this case. So what's happened here? The interluminal pressure increases. This also in turn causes pressure from within there, causing ischemia. causes pressure. So this is how the pathology starts. Okay, so I think I am talking, I'll show you some pictures. Now you have to identify what they are using the knowledge what you have got now. Okay, so let's move on to the PPT. Yes, the first picture, what is it? This is a cut section of the appendix. Can you make out what it contains? Fecal matter. So this is also hard. This is something like a fecal concretions, fecolith. Yes. The next one. This is appendix. The tip of it, which is cut longitudinally, and what do you see? This is the lumen. Lumen has hemorrhagic material here. See, all these are the congested blood vessels. Okay, lumen has got an yellowish mass. What is an yellowish mass well circumscribed like this? All of you know about lipoma, which is a benign tumor of adipose tissue. But no, I told you at the tip of the appendix, an yellow tumor that occurs is carcinoid. This is how carcinoid appears. Yeah. What are this? This is lumen of the appendix. Okay, these are not any glands or anything. So they're all transverse sections of something. See, all these they're not native to our body. All these have thick chitinous wall, such a nice wall. And if you carefully see, this is the cervical region. They have two thorns like. Okay. See? Such spikes, projection. All of them have. And this is a female. Why? Because it has got something. So, what did I tell you about the causes for obstruction? Knee parasite. So these are all cross sections of Enterobius vermicularis. So these are the eggs. You are learning about this in parasitology, microbiology, and the very nice plano-convex eggs which are non-bile staining. So imagine this lumen has so many, so easily about 15 pinworms. So this is how they appear. Very thin, they're just few millimeters and about say 5 or 4 millimeters in length. So these are all the causes for obstruction. So gross appearance, how it will be? All features of acute appendicitis. So you have learned the cardinal signs of acute appendicitis: Kaller, Ruber, Dollar, tumor, functiolasa. So all features would be there, and of course Kaller-Ruber is because of the congested blood vessels, and it all depends on what stage is this acute appendicitis. Okay, Kaller-Ruber, Dollar, tumor. Tumor is the organ would be enlarged, swollen. Yes. Then Kaller-Ruber, hyperemia. This is the one which causes that. Then suppuration, pus. Suppuration is pus. So pus is an exudate that is formed because of acute inflammation. So even the serosa, the outermost layer, could be coated with fibrinopurulent exudate. And this acute appendicitis has its own progression. It may resolve or it may proceed to become acute gangrenous, or it may perforate and lead to complications, or may become recurrent and chronic. Okay, so let us see these specimens now. So how each of these appear in different scenarios. Okay, let's see how acute appendicitis appears grossly. So I have put a lot of pictures so that you can appreciate all this easily. Okay, the first specimen, You know the cardinal signs of acute inflammation now. So here you can make out the serosa with congested blood vessels. What can you make out here? Again, see how edematous is the appendix and lot of congested vessels on the surface. It is reddish. Some amount of pus appears to be oozing out. And here the serosa is covered with fibrinopurulent material. So the inflammation has spread to the serosa also. In previous two we didn't see this. See, this is again the purulent material and congestion. So cut section we can make out the lumen has, see the irregular areas. So here it appears to be obstructed and hemorrhage and necrosis. This is the entire longitudinal cut section of the appendix. Now here we are seeing the tip of the appendix which is covered with fibrinopurulent exudate. It's the pus with the fibrin which is coating the surface. And how did this happen? So continuous, yes, here there is a perforation. The exudate has escaped or it has infiltrated through and through all the layers and perforated and come out. So this is erythema congestion. So this is another longitudinal cut section. So we can make out some concretions here. So these are the fecal concretions, and why this entire specimen has turned blackish. So this is a gangrenous appendicitis, a complication of appendicitis, acute appendicitis. So if you can see all this, you can make out that these are in different stages of inflammation. So I've shown you only acute inflammation, so not a chronic or a recurrent inflamed appendix. Now, so grossly, yes, so we have seen all these features, but now we need to confirm it microscopically whether it is chronic appendicitis or acute appendicitis, or what is the microscopic pathology. So what do we say? We have taught you that the characteristic cell of acute inflammation is neutrophil. Okay, so presence of neutrophils. So where are they present? Early they may be at the base of the crypt, but histological, many people say the diagnostic histological criteria is presence of neutrophils and muscularis, but just remember transmural neutrophilic infiltration is characteristic of acute appendicitis. What is transmural? That means we see acute inflammatory cells, that is neutrophils, in all the layers. Okay, we discussed 4 layers. Now here you remember mucosa, submucosa, muscularis. Then it can go on to serosa, and this pus or purulent exudate could be present in the lumen also. Okay, it's time for us to see the microscopic appearance. Okay, so this from the serosa, the inflammation can extend on to the mesoappendix, the fat also, and the inner layer, that is the mucosal layer, could be ulcerated. So when in gangrenous or hemorrhagic necrosis is there, many a times we do not see the mucosa at all. So entire mucosa will be necrotic, and blood vessels, they could be thrombosed also. So ischemia again causing inflammation. So this is a histological picture, diagrammatic representation. The columnar mucosal cells, the neutrophilic infiltration. So this is how the neutrophils appear. You have seen them in blood smear. They're seen as smaller cells in the tissue sections. So they do show nuclear, segmentation. They all look like ants. See? Let us see that. Then congested blood vessels. So when we see this microscopically, you can appreciate. So this is again hemorrhage. Along with that, lot of neutrophils. So inner mucosal lining. See, it is ulcerated here. Can you make out? There is discontinuity. And normally also mucosa has lymphocytes, but amidst these we have to identify neutrophils. These are congested vessels. Okay, so this is serosa with periappendiceal fat which is inflamed. Okay, so let us just look at the microscopic appearance of these slides. See, this is the lumen of the appendix. You can make out the mucosa. See all these glands. See, very rich lymphoid tissue, of course, in the submucosa. But what we are seeing is the lumen. See, lumen has something. Normally, we don't see this, right? So, all this is the exudate in the lumen. And these are the mucosal cells. These are the glands. Maybe there is slight discontinuity here. See, we are not seeing such columnar cells here. A tiny area of ulceration. Okay, I'll just go to low power. So I'm just adjusting high power now. So appreciate the cells. What are these cells that are seen here? Can you appreciate? These are neutrophils. 1, 2, 3, 4, 5. Just see their nucleus. So I focused an area. This is what we were seeing, the lumen, and all these are neutrophils. So this is the exudate that is present in the lumen of the appendix. So this is the mucosal lining. So some amount, this looks like fibrin. See, all these are acute inflammatory cells. I'm sure now you can appreciate the morphology of neutrophils very well. See, 1, 2, 3, 4, 5, 6. Most of them are neutrophils. See, all these cells which have got nice segmented nuclei. Yes, it's very well made out. Yeah. See here, aggregate how it is. This is the lamina propria now. So there are, they're normally seen also lymphocytes. There are occasional eosinophils. That's again normally seen. So there are few neutrophils here. See neutrophils. Yes, let us move on to the next one. This is a gross slide and a very easy slide for you to identify. So when you're looking at the sections on the slide, you can make out this is appendix. We have taken 3 sections for study. Okay, slightly blurred this image. Okay, so let us look at some more areas of this appendix. Now you are able to identify. See the lumen, the mucosa, submucosa lymphoid follicles. I'm just moving the slide towards the serosa. This is just the low power. So we'll move on to the next higher magnification. See the muscle layer, how the muscles are separated, and there are all inflammatory cells there which are infiltrating the in between the muscle bundles. So inner circular, outer longitudinal. So that is the muscular layer. Yeah, this is high power exactly to show you the muscles, how the muscles are separated. Now there is no doubt at all, plenty of neutrophils are there. This is a neutrophil. So all these are neutrophils. So images are very clear. See a higher magnification. You can make out 3 lobes here, 3 lobes, 3 lobes, 3 lobes. You know. See, we should be able to identify how neutrophil looks in tissue sections. See, plenty of neutrophils wherever we are seeing. All these are neutrophils. So while writing a diagram, you have to depict all this. So this is the serosa. So what has happened to the serosa? There is hemorrhage. This is a congested blood vessel. Can you make out so much of loose area there? So that is the edema, serosal edema, congested vessels. I showed you grossly all those markings which were there. They are the ones which are looking like this under microscopy. So serosa, congested blood vessels. Even serosa has inflammatory infiltration and then hemorrhage. Okay, so let us see one more picture of the same, higher magnification, and see, very clear inflammatory cells. So where are we now? I'm just showing you this in the lumen of the appendix. So plenty of neutrophils here in the lumen. So very, very clearly made out. All these are neutrophils. So if you were not able to appreciate them earlier, now look at it. This one is so clear. This is so clear. This is nice. So whenever we see these lobated nucleus, we know they are neutrophils. See, 1, 2, 3. That's what we say ant-like. You know, it looks, they're all ant-like nuclei. Very clear cut. So the neutrophil is the characteristic cell of acute inflammation. So this is purulent material or the exudate that we have seen. Yeah. Where are we now? This is the serosa. So I'm going from the periphery towards the lumen. This is serosa. This is muscularis layer. See, longitudinal and circular. Outer longitudinal, inner circular. Okay, the congested blood vessel. See, so much dilated and congested blood vessel. Edema here. See, such prominent. They would be seen very well on the serosa. See, look at inflammatory cells. Yeah, this we saw. We are seeing it again. The classical feature. Again, I'm moving towards the serosa. Inflamed. Yes. Congested blood vessels. See, so much of inflammation of the serosa. Section is folded there. Neutrophils are so well appreciable. Areas of hemorrhage are there. So all these are RBCs, you know, areas of hemorrhage I told you. Then inflammatory cells and congested blood vessels. See, entire areas of blood vessel which is congested. So muscular is over. Moving towards the mucosa. See, this is a mucosa. It is a lymphoid follicle coming towards the mucosa, mucosal glands, then the purulent material. Very classical slide of acute appendicitis. See the lymphoid follicle, so the lower power view, mucosa, submucosa. So lumen, exudate, the mucosa. Yes. So here you are seeing the muscular layer, serosa, and what else? What is extra that is seen here? This is the periappendiceal fat. So what has happened? The inflammation has spread to the surrounding fat. See, normally histology of fat, we don't see any cells like this, which are aggregated. So all these are neutrophils which are there in the septa. See, dense inflammation. If you see this in high power, there are similar cells. See, they're all acute inflammatory cells. There are few chronic also. So here the inflammation has spread to the appendiceal, periappendiceal area also. So what have we learnt about the microscopy? The characteristic feature is transmural neutrophilic infiltration. That is neutrophils in the lumen, neutrophils infiltrating all the layers, it is mucosa, submucosa, muscularis and serosa, and it may extend on to the periappendiceal fat also, and the mucosa may be necrotic. So here we are not, we are focally seeing ulceration, that's all. See, if we continue this columnar cells, maybe focally it is lost. So all this is the exudate that is seen in the lumen. Yeah. So mucosa. I've taken enough time to show you people again and again the classical morphological microscopic feature of acute appendicitis. So serosa, the muscularis layer. See how the inner circular muscle, how it is separated by the inflammation, edema and all that. That's why it appears swollen. Yeah, the entire lumen. So from lumen towards serosa we are going. Muscle, that is the serosa, and the fat. All the layers we have seen now. So there is transmural acute inflammatory cell infiltration, transmural neutrophilic infiltration, a very characteristic feature of acute appendicitis. So I'm just trying to focus this under high power. All this is fat. So you have learnt about why fat appears empty also, and how we demonstrate fat with frozen section. This is the lymphoid follicle, that's why we are seeing lymphocytes there. Some eosinophils are normally there because of constant antigenic stimulation. See, so much of inflammatory cells. Okay, so this is again the low power view of acute appendicitis. So you're going to draw a neat diagram of this acute appendicitis. Okay, so what next? What should we learn? Complications. What happens if it is left like that? sometimes it may become, the inflammation may resolve, or it may progress. So if it progresses, there could be appendicular abscess. So the entire lumen of appendix could be filled with pus. It is empyema appendix. So that can rupture. So when it ruptures, the pus is liberated outside. So it gives rise to localized abscess in the surrounding area. And a perforated appendix, a gangrenous appendix could also perforate. Then it can give rise to peritonitis. And the abscess which we were talking about, the pus purulent material, that is the infection can spread to other sites. That is, it can cause subphrenic abscess. So where does the pus collect? That is between the liver and the diaphragm. Then it can go into the pelvis, that is in between the urinary bladder and the rectum. And in females, it may even involve the uterus and fallopian tubes. And as it heals, so there's always some complication. It can cause adhesions, that is the late complications. That is fibrosis, which brings the surrounding tissues to get adhere to each other, especially to the greater omentum, small intestine, other abdominal structures. Then portal pilae phlebitis, that is the infection can spread into the mesenteric veins. Then it may produce septic phlebitis or liver abscess. And mucocele, so distension of the appendix by mucus. Remember, we were talking about mucocele of the gallbladder, white bile. Remember, I was telling you, when there is complete obstruction to the gallbladder. So similarly here, obstruction, so mucus contents may get stagnant in the appendiceal lumen, so that is mucocele. And even this can rupture, sometimes giving rise to what is called as pseudomyxoma peritoneal. So these are all the complications that we have to remember in relation to acute appendicitis. But what is important is when we are looking at the gross specimen that is given to us, so what type of inflammation is there? And classical signs of acute inflammation, I have told you, I have shown you enough gross specimens also, and microscopy, I have shown you how we make a diagnosis of acute appendicitis. And take home message here is, neutrophils are the characteristic cells of acute inflammation. And in acute appendicitis, transmural neutrophilic infiltration is one of the criteria, important criteria. Okay, so let us all draw a nice diagram of acute appendicitis. So draw this on a neat sheet. So bring them back. So when your records are given to you, please cut it and paste it in the record. And then we give you the slide once you come back to observe on your own with the microscope that is provided to you. Yeah, let's draw a nice diagram. Okay, put a circle. Girls, wearing bangle is advantage here. See, okay, I've seen many boys also getting bangles. It's so nice. Whatever work you do, it should be neat and perfect. Okay, a circle. Now we are writing only part of the appendix. We're not showing the entire appendix. See, I'm drawing the outline of the mucosa. Okay, that is the lumen. This side is the mucosa, the basement membrane, what I wrote. So now mucosa is lined by columnar cells. So let us draw columnar cells. Please write along, and focally let us not draw the lining. This is indicating there is necrosis. So then, or ulceration, what do you say? Then the nuclei for these columnar cells. Okay, you have to write along with me. Yes. So what should we write in the lumen now? Lumen has exudate. So what does exudate mean? It is purulent material. Okay. So plenty of neutrophils let us draw. So you can draw the outline of the cell and then write the nucleus within. I'll show you another way of writing the neutrophils. You may use blue pencil itself, hematoxin, fine. So those who have not taken hematoxin eosin, you can use blue and red. Okay, this nucleus is lobated. We always say ant like nuclei. See, we're not drawing a single round nucleus. We are showing segmentation. That means we are depicting neutrophils. I've just written only few. You can fill the entire area. See, the other way of writing is first write the lobated nuclei. See, then write the cellular outline or the margin. That's also easy. Okay, so this is the fluid part, that is the fibrin and the proteinaceous material of the exudate. Now you could see in the slide which I showed you. Now next is the glands. We said they all look like intestinal glands, but lot of goblet cells would be there. So few glands you can write. To show goblet cells, make them plump, having mucin. So the nuclei for these glands. Yes. Mucosa actually has plenty of lymphocytes. Now let us show submucosa. Submucosa is composed of lymphoid follicles. Important feature what we observe. I am just going to write only one lymphoid follicle, of course with a germinal center. I told you primary and secondary lymphoid follicles. Yeah, this depicts the submucosa. Okay, don't just write lymphocytes as dots. Yeah, this is submucosa. Now, next layer is muscularis propria. So, inner circular, outer longitudinal. I'm just writing smooth muscles here. A lot of space is left between because of the edema and the inflammatory cells, exudate, which is separating the muscle bundles. So outer longitudinal muscle layer. I am just writing this in a normal pace. You also should be quite quick enough to pick up and write. So what is this? Next layer is serosa. These are two outlines of the blood vessels I have shown. So congested blood vessels. I am writing the endothelium here. Nuclei of the endothelium. Yes. So fill these with RBCs. I don't have an orange color pencil, so I am using eosin. So use red or orange to show RBCs. So they are congested. And this is the serosa, which is also inflamed. So we have written all the layers. Now important feature is now lot of neutrophils. So transmural neutrophilic infiltration. So I am writing the outline of the nuclei so that I am writing the nuclei themselves. So it's easy to draw the cellular marking or the cell outline. Okay, now with this you are very clear that Neutrophil is the characteristic cell of acute inflammation. And acute appendicitis, we see transmural neutrophilic infiltration, or especially the muscular layer with neutrophilic infiltration is the characteristic feature. Yeah, I'm drawing plenty of lymphocytes in the mucosa now, because normally lymphocytes are there, lymphoid follicles are there. Just their presence does not mean to say there is chronic inflammation. Okay, putting outline for the cells. This is a higher magnification picture. So we are seeing the cells very clearly. Yes, seroso also you can write few neutrophils. Yeah, this is like write along. You people should write along with me.